Let me tell you about a patient I will call David. 68 years old, lives in the UK, retired school teacher. He had COPD, diagnosed 6 years ago. And by every measure, he was doing the right things. He stopped smoking the day of his diagnosis. He was on his inhalers. He attended his annual checkup with his doctor. He walked his dog every morning, shorter distances than before, but he walked. But in 18 months, David had been admitted to hospital 3 times, 3 COPD exacerbations, 3 courses of oral steroids, 3 rounds of antibiotics. His COPD team reviewed his inhalers after each admission. They optimized his treatment after each admission. And yet, the 4th exacerbation was already building. His wife told me something that stopped me in my tracks. She said, "He's exhausted in the mornings, doctor, more than he is at night, and he snores so badly. I moved to the spare room 2 years ago." Nobody had ever asked David a single question about his sleep. Not his GP, not the respiratory nurse who managed his COPD, not the junior doctor who discharged him after his 2nd hospital admission. When I reviewed David, he had severe obstructive sleep apnea. He was stopping breathing, fully stopping over 300 times every single night, and his COPD team had never once tested for it. Every single hospital admission had been driven, at least in part, by a condition nobody had looked for. A study published in Chest Journal and other reviews have found that COPD patients with untreated overlap syndrome can have a higher risk of exacerbation and hospital admission compared to COPD alone. This is not a rounding error. This is the difference between staying at home and ending up on a hospital ward. I know some of you are thinking, my doctor has never mentioned this to me either. And this is exactly why I'm making this video. I'm Dr. Suman Paul. I am a respiratory consultant working in the NHS and private practice here in the UK, and a principal investigator in respiratory clinical trials. I have spent 15 years treating COPD and sleep-related respiratory disease. And overlap syndrome is one of the most underdiagnosed, undertreated, and most consequential conditions I see in clinical practice. Before we go further, I am a doctor, but I am not your doctor. This video is for education only, not personal medical advice. If you are struggling with breathing right now, please call 999 immediately or see your doctor. Here is what I am covering today. 6 things your COPD is doing while you sleep, ranked from important to absolutely critical. And I will tell you right now, number 2 on this list surprised even me when I reviewed the clinical trial data. Most of my patients had been doing something wrong for years. Stay with me to number 1 because what I share at the end of this video connects every single piece of this together. First, what is overlap syndrome? The name is straightforward. It is what happens when COPD and obstructive sleep apnea exist together in the same person at the same time. Both conditions damage your airways. Both reduce the oxygen your body receives. Both drive inflammation deep inside your lungs. But together, they do not simply add their effect, they can amplify each other. During the day, your damaged COPD airways are managing. Breathless, perhaps, but managing. At night, when obstructive sleep apnea causes repeated airway collapse, those already compromised airways have less reserve left to recover. Each apnea event, which means you stop breathing, drives lower oxygen, holds it lower for longer, and floods the body with stress hormones that worsen strain on the lungs and heart. This is not a rare condition. COPD OSA overlap syndrome is common enough that it should be actively considered in COPD patients, especially when symptoms suggest sleep disordered breathing. Now, 6 items, starting at number 6, and I want you to pay close attention because what your body may already be telling you could be more important than anyone has let you know. Number 6, and this alone should change how you think about your COPD. COPD OSA overlap syndrome is common enough that it is often missed and many patients are never formally assessed for sleep apnea. In the UK, diagnosis of OSA can take years once symptoms begin. During that entire window, your lungs are fighting on two fronts simultaneously every single night. A systematic review and other summaries have found that COPD patients with comorbid OSA have higher healthcare use and more severe nocturnal oxygen issues than COPD alone. There is a validated questionnaire called Stop Bank. It takes less than a minute. If you score 3 or above, you should be asking whether an overnight sleep study is appropriate. Write that down and do not let anyone tell you it is just your COPD. The symptoms most people dismiss as ordinary COPD, like morning fatigue that does not get better, snoring, waking during the night, difficulty concentrating through the day. These are also hallmark symptoms of untreated sleep apnea. In a COPD patient, they are a red flag, not an inconvenience, a signal. But here is something even more important you need to understand about what is actually happening inside your body when these apnea events occur. Because the oxygen story goes somewhere most COPD patients have never been told, and it is genuinely serious. Number 5. This is where the biology of COPD and sleep apnea collide in a way most patients have never heard explained. In a healthy person, an obstructive apnea event can drop oxygen saturations significantly. But the body often recovers more quickly because healthy airways can restore that oxygen fast. A COPD patient's baseline before the event may already be lower than normal. That same apnea event can take them farther down, and recovery may be slower because damaged airways cannot compensate as quickly. This is why nocturnal desaturation in overlap syndrome can be so dangerous. Research in COPD OSA overlap syndrome has shown that oxygen desaturation event can be more prolonged and more severe than in OSA alone. Here is something practical you can do tonight. Hope pulse oximetry is widely available. A finger oximeter for under 20 pounds, or you can use some of the health watches like a Garmin or Apple Watch. If your readings are dipping below 88% during sleep, that is information worth taking seriously and discussing with your respiratory team. Take that data to them directly. You will need a formal sleep study for confirmation. 2 down, 4 to go, and we are getting closer to number 2. The item I told you would surprise you. Something that involves a habit most COPD patients repeat every single morning. Without knowing, it has direct consequences for the most dangerous hours of their night. But first, I want to ask you something directly. Are you currently being treated for both COPD and sleep apnea? Leave your comment below. Your experience tells me what information is actually reaching patients and what is not. I read every single comment. And if this video is helping you, please share it with someone who has COPD. COPD OSA overlap syndrome is underdiagnosed and undertreated. Your share could be the reason someone finally gets the right diagnosis. Next is something that patients experience every single morning and almost never connect to what their lungs were doing the night before. A symptom hiding in plain sight. Number 4, and this is the one that in my experience comes closest to being completely invisible to patients. Many COPD patients already retain CO2 during the day due to air trapping. When the air's cannot fully empty, carbon dioxide accumulates in your bloods. It is known feature of moderate, typically severe COPD. But during sleep apnea event, CO2 can build further. And here is what makes this specifically dangerous in a COPD patient. Unlike a healthy person, a COPD patient may not be able to compensate as effectively overnight. The result can be a nocturnal hypercapnia, means raised CO2 in the bloods. CO2 building in the blood during sleep, reaching levels that impair brain function, strain the heart, and acidify the blood. The symptoms patients experience and never connect. Waking with a headache, not occasionally, regularly. Feeling completely unrefreshed regardless of how many hours you slept, grogginess that takes a long time to clear, a racing heart on waking. Most people put this down to poor sleep quality. It may be, But in a COPD patient, it can also be a clinical signal. If you wake up with a headache more than twice a week, tell your respiratory team. Morning headaches in COPD are not something to ignore. They deserve assessment. Now, number 3. This is where I want to return to David, the patient from the beginning of this video, because the full picture of what happened to him reveals something about how COPD exacerbations are actually driven in overlap syndrome and why it is important to look for more than one cause. Number 3, this one I find the most difficult to talk about in clinic because it is entirely possible to miss. And I continue to see it in patients who have been in the COPD system for years. Here is the mechanism. Each night of untreated OSA in a COPD patient triggers hypoxia, which means low oxygen level in the blood. Hypoxia drives an inflammatory cascade, which is a lot of chemicals like interleukin 6, TNF alpha, and many more, flooding the airways and the bloodstream. That inflammation worsens the underlying airway damage from COPD. FEV1, which is the amount of air you're breathing out in 1 second, can decline faster than it should. And the threshold at which the next exacerbation is triggered becomes lower, night after night, month after month. In plain language, every bad night of sleep may be quietly making your COPD worse. Not dramatically, not in a way you feel the next morning. Slowly and silently until something tips over and the next exacerbation arrives. Studies and reviews have found that COPD patients with untreated overlap syndrome have more exacerbation and hospital admission than those with treated disease, and CPAP treatment is associated with better outcomes in a overlap syndrome. Now David, 3 hospitalizations in 18 months, optimized inhalers, non-smoker, doing everything right, but each exacerbation was a cumulative result of the months of nightly airway damage that had been building invisibly while the sleep apnea was missed. I will tell you exactly what happened to David at number 1 because it connects to everything on the list. Number 2, the item I told you would surprise you, and the one that involves something most COPD patients do without a second thought every single morning of their lives. Something that may be working against them at the most critical hours of the night. Number 2, and this is the one that consistently surprises patients most because it involves something they do every single morning without a second thought. In studies assessing inhaler use, the majority of COPD patients, sub-reviews suggest over 70%, demonstrate suboptimal technique of inhaler use. Not occasional errors, consistent errors every dose, every single day. Here is why this matters specifically in overlap syndrome. COPD and sleep apnea together place exceptional demand on your airways throughout the night. Your bronchodilator, your LABA, your LAMA, or your triple therapy is your protection. It keeps those airways open as much as possible while you sleep. But if only a fraction of each dose is actually reaching the lower airways due to incorrect technique, you are sleeping each night with significantly less protection than your prescription should be providing. It is not what most people think. They assume if they pressed the inhaler and breathed in, the medication arrived. That is not how it works. The most common errors I see in clinic: not coordinating the breath with accentuation on an MDI, breathing in too slow through a dry powder inhaler, which requires a fast breath to deposit the medication correctly, not holding the breath for 5 to 10 seconds after inhaling, not shaking an MDI before use, and in patients with more severe COPD, not using a spacer device when one is clinically indicated. Here is the game-changing part most people miss, and I include many clinicians in this. A spacer can increase the fraction of medication reaching the lower airways from as little as 10 to over 30% in some patients. That is not a minor adjustment. That is a fundamentally different level of treatment. But there is something even more important you need to understand. What patients describe they do and what they actually do in clinic are often not the same thing. That is not a criticism. it is human behavior. We habituate to routines. We stop noticing the details. Here is exactly what I want you to do next week. Not when you have a spare moment. This week, ask your doctor, pharmacist, or respiratory nurse to watch you use your inhaler from start to finish. Not explain, watch. Most pharmacists will do this without an appointment. Remember this, if your COPD treatment is not controlling your symptoms as well as it should, before asking for a stronger medication, confirm that the medication you already have is actually reaching your lungs. Correcting technique costs nothing. In my clinic, I see patients whose symptom control improves meaningfully from this single change alone. And number one, the item that ties every single piece of this together, it is not a new drug. It is not something sitting in clinical trials. It is the correct combined treatment of two conditions that most COPD patients in UK are currently receiving treatment for only one of. Number one, the overlap treatment protocol. CPAP therapy alone, when correctly fitted and consistently used, can reduce symptoms and improve outcomes in overlap syndrome. The evidence for this is established. Optimized inhaler therapy, LAMA or triple therapy, also reduces exacerbations. That evidence is established too. But here is what most COPD patients in the UK are not being told. The combination CPAP overnight plus optimized COPD therapy can reduce hospitalization risk in overlap syndrome patients. CPAP is not a device for snoring. For a COPD patient with overlap syndrome, it is respiratory protection. Every night you sleep without it. When you have both conditions, your airways are under attack, not occasionally every single night. I want to say something here that I think matters, and I say this as a principal investigator in respiratory clinical trials. The gap between what the trial evidence shows and what actually reaches patients in clinical practice is one of the most significant problems in respiratory medicine today. Overlap syndrome is one of the clearest examples of that gap. The data has been there for years. The implementation, the routine testing for sleep apnea in COPD patients, the combined management protocols, the education of patients about inhaler technique has not caught up. That is not an acceptable situation for patients who are being admitted to hospital for exacerbations that may be preventable. Now, David. After identifying his overlap syndrome, David was started on CPAP therapy. His inhaler technique was formally assessed and corrected. No new medications, no additional treatments. The treatment he needed had been available for 4 years. He simply had never been tested and therefore had never been treated. His exacerbations in the following 18 months, 0. He told me at his last review that he had forgotten what it felt like to wake up breathing properly. His wife moved back into their bedroom. He's back to walking his dog every morning, not shorter distances. The same ones he walked before his first hospitalization. Before I close, here is exactly what I want you to take away from this video. Not just information, action. 5 practical steps starting today. 1. Complete the Stop Bang questionnaire. It's available if you just Google it. If you scored 3 or above, request a referral for an overnight sleep study. If you want to get it done privately, book an appointment with me. Link is in the description box below. 2. If you regularly wake up with a headache more than twice a week, flag this directly with your respiratory team at your next appointment. Morning headache and COPD are not normal, they are a signal. 3. If you have home pulse oximetry, wear it overnight. If your readings dips below 88% consistently, that data needs to be discussed with your respiratory physician. 4. Ask your GP, pharmacist, or a respiratory nurse to watch you use your inhaler from start to finish this week. If your treatment is underperforming, this is the first place to look before requesting a different or a stronger treatment. 5. If you have had more than one exacerbation in last 12 months and your inhalers are already optimized, the next conversation you need to have is about your sleep. Not more inhalers, sleep. One final thought, and I believe it is the most important thing in this entire video. A COPD diagnosis is not a life sentence. It is a signal to be more precise about your care, more deliberate, more informed. The reduction in hospitalization risk for overlap syndrome patients who receive the correct combined treatment is not just a number in a research paper. For David, it was a difference between 3 hospital admissions and 0. For someone watching this video tonight, it might be the difference between a COPD exacerbation next winter and a night sleeping properly in your own home. If this video helped you, please share it with someone who has COPD, because COPD OSA overlap syndrome is underdiagnosed, undertreated, and completely manageable when it is correctly identified. Your share could be the reason someone finally asked the right question at their next appointment. Subscribe to this channel for more evidence-based respiratory content. Every video I make is built around the information your appointment may not have had the time to cover. And if you would like to discuss your own respiratory care with me, I see patients privately at Liverpool, Manchester, and the Cromwell Hospital, London. No GP referral is needed, no waiting list. The link is in the description box below. Now you understand what's happening to your lungs every single night. But sleep is only one part of the picture, because even patients who get the right treatment still watch their lung function decline. And the reason almost nobody talks about is what's happening during the day. Check out this video where I show you exactly how to slow the progression of COPD and the specific steps you can take right now to protect the function you still have. See you on the other side.